everyone. My name is Danaithep L, and I would like to talk about key radiographic assessment of the dysplastic hip. Okay, so we're going to start off with the measurement. So I think some of you are familiar with the measurement of the hip, especially the AP view, or the anteroposterior. Okay, here we have a musculoskeletal radiologist with us today in this room. Okay, let's see if I made a good presentation. So I would like to emphasize on the position of the pelvis AP. Many of you are familiar with the film, but I guess that maybe less than 10% would probably check whether the technician have made the proper position for the X-ray exposure. This is very crucial for the interpretation of the image acquired from the X-ray. So I think we should pay a little bit of attention in this. So the AP pelvis radiograph is acquired with the patient supine, as you may have known, and the legs 15 degrees internally rotated to compensate for femoral antitorsion, and the X-ray beam centered to the midpoint between the upper part of the symphysis and a line connecting the ASIS. So first off, we're going to start with the acetabular depth, which can be seen if the hip has the coxa profunda or not. Coxa profunda is the acetabular fossa touches or crosses the ilioischial line, or the other thing is protrusion acetabuli, which is the femoral head touches or crosses the ilioischial line. Next is the acetabular coverage. For the acetabular coverage, the LCE, or the lateral center edge angle, is an angle formed by a vertical line and a line through the center of the femoral head and the lateral edge of the acetabulum. The angle of lower than 20 degrees is suggestive of dysplasia. The other is the tonus angle. It's an angle formed by a horizontal line in H in the picture and a line through the medial and the lateral edge of the acetabular roof. The angle of more than 10 degrees is suggestive of dysplasia. Next is the acetabular orientation. First is the posterior wall sign, which is positive if the posterior wall runs medially to the center of the femoral head. Next is the crossover sign. The crossover sign is positive when the anterior wall crosses the posterior wall. And the other is the ischial spine sign, which is positive if the ischial spine is projected medially to the pelvic rim. And last, which is, I think, probably the easiest, especially for the younger residents, is to check the joint congruency, which is the Shenton's line, whether it is intact or interrupted. The Shenton's line is the line from the caudal femoral head neck contour and the superior border of the obturial foramen. If it is interrupted, it does not form an harmonic arc, which in this case, it is interrupted. A study in 2015 in CORR has made about 500 to 600 hips and studied the parameters of the hip from the dysplasia hip, normal hip, and some overcoverage of the hip, and find which is the sweet spot for the parameters of each measurement. So for the normal hip, the lateral center edge angle is about 23 to 33 degrees, where the dysplasia has less than 22 degrees. The tonus angle, in contrast, for the normal hip is about 3 to 13 and is suggestive of dysplasia if the measurement is more than 14. The crossover sign is obviously positive in dysplasia, and also the posterior wall sign, and the Shenton's line is positive when the hip is subluxated. Now let's look at the radiograph that we all know that the primary imaging modality is the radiograph, which we use every day. except for maybe today because we're in a meeting. And it must be emphasized that despite the increasing availability of modern imaging technologies, conventional pelvic radiographs has not lost its role in the preoperative workup of dysplastic hips. It remains a mandatory tool for the assessment of the dysplastic hip, treatment planning, and postoperative evaluation of the performed correction. So, what are the technical principles regarding the radiographs, which we send almost every day? So the plane radiograph is basically a two-dimensional projection of a complex three-dimensional anatomy and is significantly influenced by the following parameters: the conical projection, the film tube distance, patient to film distance, centering and alignment of the X-ray beam, and pelvic orientation during acquisition. So we're going to go through each of it. So first is the conical projection. So the X-ray are based on a point-shaped X-ray source and a conical projection. Therefore, distortion of the anatomy is unavoidable. So typically, the more interior an object, which in this case, the interior rim of the acetabulum, is located to the X-ray source, it will be more lateral and distorted. So the key here is to keep the X-ray source away. Next is the film tube distance. The anatomy of the hip is also affected by the film tube distance. The apparent acetabular anteversion increases with the increasing film tube distance. In contrast, with decreasing film tube distance, which means the X-ray source comes closer to the patient, the anteversion decreases and the acetabulum may appear retroverted. The apparent retroversion becomes more pronounced, indicated by a more distal crossing of the interior wall and the posterior wall, as indicated on the picture on the right. Next is the patient to film distance. So we have a variety of patients in our hospital, and probably yours as well. So on the transformation of the hip on the radiograph, the patient film distance has only minor influence. For an individual patient, the patient film distance usually remains consistent, even though inter-individual differences exist, since the increased body volume mainly affects the interior part of the body, even in very obese patients. The distance between hip joints and the table shows minor variation. Next is the anatomy of the hip and on a plane radiograph, which directly depends on the centering of the X-ray. So in this picture, when moving the center of the X-ray from the center of the pelvis to the center of the hip, the acetabulum becomes more anteverted, which indicated by a more distant course of the interior and posterior acetabular wall. In addition, the acetabulum appears deeper with a positive coxa profunda sign, which is the line in green dashes, and you can see that it is more pronounced. Next, if whether the pelvis is centered or not. So in this picture, the pelvis on the left is centered, whereas on the right, the pelvis moves up a little bit. So on the pelvis-centered radiograph, the acetabulum is retroverted, indicated by a crossing of the interior and posterior wall and a positive ischial spine sign. So when the center is lowered on the picture on the right, you can see that the crossover and the ischial spine signs are negative, and therefore an acetabular retroversion would have been missed. So this is another key if you try to interpret the film in the hips X-ray instead of the pelvis AP. Okay, so in conclusion, I think the key here for the radiograph is probably the position. And of course, we all know that radiograph is the primary imaging modality. So I think we should all pay attention to the position and interpretation of the X-ray film. And of course, all the technical principles that I've said previously must be kept in mind for accurate measurement and interpretation. And here is the parameters again, which I have shown previously. Okay, thank you all for your attention.